Buenas tardes. I would like to thank the organizing committee and the members, and more importantly, my friends, for allowing me to be part of this meeting. I'm looking at the cast of characters, and they come from all throughout the world. And I think this really comments on pediatric nephrology, that we see the world as our friends and we see our patients as our bosses. So thank you for allowing me to be part of this. Am I correct in thinking you can see my screen okay?
Sí, doctor. La presentación se ve bien.
Thank you. Thank you. So I've been asked to talk about renal replacement therapy for intoxications. And it's an area that has less frequency than it used to be, yet at the same time is still something to think about. And I'm going to leave at the very end with some ideas, but let me walk you through the current state-of-the-art science. So I want to compare and contrast the difference between an intoxication and an inborn error of metabolism. We know that intoxications, we believe, are a one-time event, with the only issue is the need for removal via either natural metabolism, meaning liver or kidney, or via some sort of extracorporeal therapy. This is in contrast to inborn error metabolism, which is also an intoxication. But the difference is that the production of the ammonia is persistent and unknown. Therefore, the difficulty with the hyperammonemia patients is that one only knows what the ammonia is at the beginning, but one does not understand what the production rate is. I'd like to use this as an example of a patient that all of us have seen, a 17-year-old female with a polypharmacy overdose, including risperidone, Strattera, and long-acting lithium. And I point out long-acting for a reason. Remember that some of the medications are short-acting and some are long-acting. And knowing that whether the medication is short or long-acting is critical in some of the decision-making on how to manage that patient. This young lady is not currently chronically on any medications. And 12 hours after the time of the overdose, she is semi-comatose with already EKG changes, with QT interval changes seen. And that is a sign and a symptom of lithium overdoses. In this case, she has no hepatic or renal dysfunction, and that's very critical, because the question always is, do you wait for the natural production and the decay of the toxin via natural ways such as liver or renal, or should one intervene with dialytic therapy? We can measure lithium, which is fantastic, and her level was toxic, knowing that her level was greater than 5.1, and critical in the lab of assay was greater than 4. Plus, she was having cardiac changes. So let's think about what you have to think about is your thought process for renal replacement therapy. Is the medication short or long-term acting, long or short acting? Is there any inhibition of the natural decay of the drug? Meaning, is there hepatic or renal impairment? And then when it comes down to pharmacy, one needs to know the molecular weight, the protein binding, and whether this is a single or double compartment medications. And I'll use an example of that when we get to vancomycin. Let's go back through the literature. The literature points out there's roughly over 2 million reported poisonings, and roughly about 67% or 2/3 are in pediatrics. Only a very small part, or 0.05%, require extracorporeal elimination. But the primary prevention strategies for acute ingestions have been designed and implemented. I'm not sure in Chile, but in North America right now, the #1 overdose is for patients taking their parents' gummy cannabis pills. Cannabis is now being marketed in North America as a gummy chew that many of the children see as a candy. And so in our hospital and many hospitals in North America, cannabis overdose is common. Cannabis, by the way, cannot be removed by dialytic therapy. This is the concept of one has to think about. You've got the input, and this kind of the time of the overdose, and then you've got liver, GI tract, renal, and blood excretion elimination, and whether that's reabsorbed at the same time. If this is a long-acting medication that sits in the gut for a long time, then your GI tract will continue to reabsorb this medication over time. So sometimes one has to think about hepatic excretion. Sometimes one has to think about a GI excretion with inducing diarrhea or enema, diuresis with the kidney, and also, is there anything from a blood perspective? So the general principles of intoxications is one needs to know the kinetic of the drugs, whether they're based on therapeutic or not toxic. Remember that most of the literature talks about what is the target level of a medication for therapeutic intervention, but not what is the toxic levels. Then one needs to think about what is their local resources, what are their choices of extracorporeal modality is based on availability, expertise of people, and properties of the intoxicant. Each modality has benefits and drawbacks, and is their ability to mix and match modalities or combine modalities as a therapy plan. So the classic indications for renal replacement therapy will be if the child has a prolonged time on the ventilator, if there's renal or hepatic dysfunction, parametabolism, any support, high probability of morbidity and mortality, progressive clinical deterioration, and also abnormal vital signs, coma, or and also if a drug is extractable or not. So this is a slide I made up years ago that compares really the 5 modalities that we have for dialysis. We have CRT, which was given a talk already today. We have SLED, which Sardar Sethi gave a talk on. We've got either standard or high flux hemodialysis. We have peritoneal dialysis, talked about by Mignon. And we also have CFPD, or continuous flow peritoneal dialysis, which is, if you don't know about this modality, look at Peter Norris's work that he's done out of South Africa. It's incredible. But if one looks at the relative comparison of these 5 modalities, we know that CRT, SLED, and hemodialysis needs vascular access. We know that PD and CFPD requires peritoneal access. And we know that SLED, CRT, and hemodialysis may or may not need anticoagulation. There is thermic control associated with some of these modalities. There's ultrafiltration control with some of these modalities. And there's drug clearance that is continuous versus intermittent there. But what is known is that the standard that's used in the world for drug intoxications is that of hemodialysis. So this is Frank Gotch's paper a long time ago, using the KT/V idea on comparison modality of clearance. And it looks at thrice weekly KT/V and hemodialysis versus Ronco's 20, 35, and 45 mils per kilo per hour of convective clearance. This was Ronco's 2000 paper, versus SLED, which is extended daily dialysis. And what is known is that at least thrice weekly hemodialysis is inferior to CRT, but daily hemodialysis will be superior to anything. So what do we know about hemodialysis? We know that things that can be removed need to have a small molecular weight. They need to be water soluble, a small volume of distribution, minimal protein binding, single compartment, which is probably not correct anymore. So the drugs that are classically amenable to removal by hemodialysis includes vancomycin, especially with the high flux membrane, which we'll talk about in a minute, the alcohols, lithium, and salicylates. So this is an example of ethylene glycol. Ethylene glycol, as you know, is an antifreeze common in the northern part of the world, is used as a substitution for cheap alcohol. Ethylene glycol, if left in the patient, is associated with coma, blindness, oxalate deposition of the kidneys, and death. So this is an example in a patient number 1 in the red and patient number 2 in the yellow, who had very toxic levels of ethylene glycol, who underwent hemodialysis. Normal is thought to be less than 30. Normal really should be 0 because no one should be drinking ethylene glycol. But these are very amenable to removal, very quickly. And really in a period of 4 to 6 hours, these can be removed very simply. This is a single compartment drug that when you walk away will not have rebound. This is in contrast to vancomycin. I worked with physicians who primarily, well, I won't tell you who they are, but actually think that if a vancomycin is good, a lot's better. These are very high levels. Normal is less than 40. And these are patients who underwent hemodialysis, high flux dialysis, who are over a 3-hour period of time had a rapid drop in vancomycin levels. But as you walk away, there's a rebound. This is an example of a 2-compartment drug. And therefore, in this era, and I will give you a better idea than this, but in this era, one has to then do intermittent hemodialysis in order to get the patient out of the toxic range. This is carbamazine. Carbamazine is interesting because it's a very highly protein-bound drug. It's about 90% protein-bound, and it's also a moderate molecular weight. This was a patient, this was a small child that underwent acute hemodialysis, which the books say it does not work, but we use a high flux membrane on a very small child. So this was a 10-kilo child, though we had to do a blood prime because of a large extracorporeal blood volume. We were able to clear the carbamazine very nicely. Because this is protein bound, there was a minor uptick in levels as it came off rebound, but not enough for clinical concern. So hemofiltration, or CVVH specifically, can be removed, can also be used. And typically these patients, these drugs have to be relatively molecular mass less than the cutoff of the fibers, usually less than 40,000. Also single compartment kinetics. But more importantly, hemofiltration, or CVVH, can be used sequentially, that associated with hemodialysis. So this is an example of a lithium overdose, this patient that was talked about at the very beginning, that actually the lithium came down very nicely during hemodialysis. But to avoid the rebound, the patient was started on hemofiltration. And if you look at what we did, remember this is high flux dialysis is going through at least 50 liters per hour of dialysate. Then we moved this child down to CVVH-DF, where the child then went to 8 liters. Then we marched it down to 4 liters, and we marched it down to 2 liters. And over this 48-hour period of time, we were able to remove the lithium from the patient to levels that were appropriate and no longer toxic. So this is a good example of sequential therapies, hemodialysis to convective clearance. And if you understand CRT, it's always preferred to do convective clearance over diffusive clearance. Convective clearance will give you about a 10 to 15% improved clearance of medication over diffusion. Therefore, we prefer convective clearance. So what are the medications that are amenable to CVVH? Again, vancomycin, methanol, procaine, hydrogen, thallium, I apologize, lithium, as well as methotrexate. You may have read about SPAD, which is also called single pass albumin dialysis. This paper was done by Dave Ashkenazi, who talked earlier today. And this is a patient who had a carbamazine, again, 90% protein bound overdose, that the natural decay would have been this, where there had been almost a 2.5 to 3 day clearance of this drug. What albumin dialysis is that you take a patient in a CVVHD mode. And in the dialysate, you put in about 4 grams per liter of albumin in the dialysate. And this is really a pre-runner to the Mars machine that's been used for hepatic failure. And by using albumin dialysis, you can actually pull things out of the plasma that's protein bound. The complaint about this is that in most parts of the world, including the United States, albumin is very expensive. Therefore, it's not always the preferred method in order to remove things, but it can be done. And David's study here in this case report pointed out that going from a 58 to 60-hour decay was down to about 14 to 15-hour decay, getting the patient out of the toxic levels. So Maria Ferris wrote this paper about a decade ago. Many of you know Maria. And we were asked in this paper to look at the top 10 drugs that are overdosed in children with therapy. And what we did in this paper, we looked at the top 10, vancomycin, aminoglycosides, lithium, aspirin, theophylline, carbamazine, valproic acid, metformin, and methotrexate. And what we did in this paper, which was published about a decade ago, we put in this paper the molecular weight, the volume of distribution, and the protein binding. As a rule, the bigger the protein binding, vancomycin 75%, aspirin 90%, valproic 90%, carbamazine almost 80%, it's harder to have clearance. And that's where something like albumin dialysis may be helpful, or something like high flux hemodialysis could be helpful for that. Methotrexate, yes. Methotrexate may be an issue because there's a rebound, and many of the patients on methotrexate are actually on chronic that for either their rheumatologic disease or for their hemoc disease. Let me talk about some practical points for dialysis. It is very difficult to talk about a renal replacement therapy or an extracorporeal therapy unless you can measure that toxin in a timely manner. Vancomycin, lithium, in most labs can be measured rapidly. Many of the medications, as mentioned, are two-compartment drugs. And the best example of this is vancomycin, where there's an intravascular part that you'll remove by medication, which may result in rebound, but then it goes back to the vascular space. And I go back to this slide we had before that points out on hemodialysis, if we did hemodialysis alone, you could clear your vancomycin very nicely, but it rebounds very quickly within a matter of hours. That's why we would now recommend hemodialysis first, then the use of sequential convective hemofiltration, so CVVH, in order to continue the clearance of the drug. Remember that dialysate for renal failure is associated with a dialysate bath of 0 phosphorus and low potassium. But the dialysis for intoxication should be associated with normal phosphorus bath and normal potassium bath. So you have to think about making sure you're not clearing the electrolytes that would cause downstream complications. Remember that dialysis for renal failure is associated with fluid removal, and it also but dialysis for intoxication is often not associated with fluid removal. Therefore, one has to think about their prescription. Many of the hemodialysis machines that are used throughout the world have a natural ultrafiltration of 100 to 300 mils an hour, even when the ultrafiltration is set at 0. So one needs to very seriously look at their volume status and make sure that the machine is not removing fluids where the clinician is not aware of that. In conclusion, renal replacement therapy is best used in a high flux hemodialysis and convective hemofiltration, allowing for sequential therapy. And one has to know about single or double compartment kinetics in order to determine the length of time. And also it'd be nice to have the medication or the toxin measured so one can decide if you're clearing it. I want to bring your attention to 2 different study groups that are very important. The XTRIP website, which is there in your slide, this is a group of adult intensivists, pediatric intensivists, adult and pediatric toxicologists, mostly adult nephrologists, and I happen to have the honor of being one of the few pediatric nephrologists on this group. This website is free access to anyone. And this website now has looked at over 20 publications of looking at toxin clearing. And it gives you, if you will, the best practice available now in the world of whether one has the ability or should even consider this. This website has data on on removal of calcium channel blockers, beta blockers, all sorts of vasoactive agents, methotrexate, as well as others. So I would use this as a resource in order to make the determination of whether one could actually remove the medication, and more importantly, whether one should remove the medication. I'd also like to bring you to this group. You'll see in this picture, Menya McCullough, who talked earlier today, Siddharth Sethi, who's talked earlier today, and Rupesh Rana, who's talking to, I think, tomorrow. We have changed PCRT to iconic. And the reason we've done this, we are no longer North American centric. We are world centric. We have members from your country, from every country in the world. We now have 100 members that are part of iconic from 39 countries. Our goal is very simple. Let's learn from each other. Let's work with each other. Let's look at best practice based on local resources, and let's figure out how we can take care of children. Also, let's use each other as resources. For the junior faculty and the fellows on this, I highly recommend you reaching out to our group, getting involved. We are open access to everyone. We'll get you to write papers. We'll get you to be part of our international collaborative. But we have moved from North American centric to world centric with iconic. And I think that's the world of the future. With that, I'd like to thank you for allowing me to be part of your great meeting. I apologize that I struggle with English, and Spanish is even more difficult for me. And I'm happy to be back on at 4 o'clock if necessary, or now whenever I was told, for a Q&A session. Thank you.